By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast.
Welcome, everybody, to another edition of Nets Get Real with NCAN. I am your host, Mike Wayman. I want to thank everybody who is so far signed up for the Strides for Stripes virtual walk. It's been such a great program that we've run the past 2 years. You can walk anywhere, walk your neighborhood. You can go to a local park. You can walk with your friends. You can walk with your family. You can do it anywhere you want. Just go ahead and go over to netcancerawareness.org. Make sure you sign up and start a team or join somebody else's team. It really helps us do these great programs like today. And like we did last month. Last month, we did our Net Patient Conference in New Brunswick, New Jersey at Rutgers University. And a gentleman who was very much responsible for bringing us in there is an old friend of NCAN, one of our most longtime allies, Dr. Stephen Libutti. Thank you for coming.
Good morning, Mike. Yeah, my pleasure. Thanks for having me.
Yeah. No, thank you. It's been a little while since we've seen each other. You've been very, very busy since I think the last time you spoke at one of our conferences was when you were at Montefiore in New York City. And then just moving on up, we could probably spend a whole show talking about your credentials and your accomplishments and stuff like that. But right now, he is the Senior Vice President of Oncology Services at Rutgers University. He is just a really well-accomplished doctor and scientist. And he has his own Wikipedia page. I don't know if you knew that or not.
I've been told.
Yeah, which is a first on this show. So, well, thank you very much for joining us.
Well, thanks, Mike. Thanks for having me. I feel very passionately about the work that NCAN is doing and has done over the years. I feel it's critically important. The advocacy for our neuroendocrine tumor patients is critical with rare tumor types or tumor types that don't fit, sort of the top three that are top of mind for government, for funding agencies, for the population in general. It's critically important that we continue to put the importance of covering new ground, finding new approaches, and evolving and improving treatment for a very impactful, even though it may be a zebra. And so it's a passion of mine. As you know, it's been the area of focus for my laboratory and clinical career, dating back to the beginnings of my career at the National Cancer Institute. And it's just a privilege to get to chat with you this morning.
Yeah, no, thank you very much. Before we get into some of the questions here, what I did want to ask is, could you give like a brief history of your history in NETs and your journey through the NET space?
Sure. So I began my career about 30 years ago at the National Cancer Institute in Bethesda, Maryland. And it was there that I was introduced to a variety of familial syndromes associated with neuroendocrine tumors, multiple endocrine neoplasia type 1, von Hippel-Lindau, SDHB, SDHD, and familial carcinoid syndromes. And there was a long history of research at the NCI and the associated institutes of the NIH, NIDDK, other institutes that had an interest and focus in endocrine neoplasia. And that's really where my introduction started. It was actually a hallway conversation that led me down this path. Marston Lenehan, who is the chief of the urologic oncology branch at the National Cancer Institute, and a leader, thought leader in kidney cancer, von Hippel-Lindau disease, et cetera, came up to me one day in the hallway, and this is probably about 30 years ago, and said, "Hey, I know you have an interest in the pancreas. We see these pancreatic neuroendocrine tumors associated with VHL. We have about 15 patients in a database. We're not quite sure how to approach the management. Is this something you'd be interested in helping us with?" And that hallway conversation essentially launched a career in focusing on neuroendocrine tumors. I also had the privilege of working with Alan Spiegel, who at the time was the director of NIDDK. I actually got to work with Alan at Albert Einstein College of Medicine as well when he was the dean. And he and Francis Collins and others were working diligently back then on sequencing the MEN1 gene. And I got the privilege of working on that project as part of the laboratory team. And so that's really what sparked my interest. And it's been a 30, as I said, year journey. And I'm excited about the work we're doing today as I was when I started my career 30 years ago.
That's amazing. It's amazing. And being in the field 30 years, I kind of, one of the things that I do want to highlight is that NETs doesn't necessarily mean that it's the end right away. That's one thing that, my mother, I'm sure everybody's heard the story before, is that she thought she had 5 years to live. I'm sure that's not always the case. In fact, probably a great deal of them. Do you have any patients or keep in contact with any patients from the very beginning at all?
Oh, of course. Yeah. So I have the privilege. It's one of the great rewards of being in this field is I have patients I've followed for decades and have managed their disease, basically evolving along with the field and new agents that have come on board. When I started treating patients with neuroendocrine tumors, we really had very limited tools in our toolbox. We had surgery for patients who were candidates for surgery, and we really had somatostatin analogs. That was essentially what we had available for treating patients. And over the years, we've obviously expanded that toolkit substantially as the result of a focus on research in the area. And NCAN and other advocacy groups that focus on neuroendocrine tumors have been instrumental in putting a spotlight on the importance of studying this disease. And that's directly led to some of the new discoveries that have been made over the last several decades. But yes, it is not, I tell patients when they're diagnosed, and obviously neuroendocrine tumors can occur anywhere in the body, many different sites for primary lesions. But I tell my patients when they present with pancreatic neuroendocrine tumors that this is not what you typically think of as pancreatic cancer.
Right.
This is the other pancreatic cancer. And while I don't like to minimize it, there are certain histologies that will be very aggressive. By and large, with this disease, we have some time to impact, time to strategically pull our weapons out of the safe to use on this disease. We can be a little bit more strategic and a little bit more thoughtful in terms of how we approach it.
Yeah, absolutely. And now there's quite a few more arrows in the quiver, so to speak, when it comes to treatments and stuff like that. Something you did mention while you were talking about the history, your history in NETs, is the familial studies. And I do know that is just an ongoing thing. I know that that's still a thing over at NIH. I mean, have you heard any real forward motion or any kind of news on that front? Are there definitive familial connections to the disease?
Well, yes. When we look in through the broad lens of neuroendocrine tumors, we know that we see pancreatic neuroendocrine tumors, gastric neuroendocrine tumors, what had typically been referred to as carcinoids, duodenal small bowel neuroendocrine tumors associated with a variety of familial syndromes. Multiple endocrine neoplasia type 1 is one of the more common ones that we make this association. In MEN1, we see pancreatic neuroendocrine tumors that can run the spectrum of non-functional or functional tumors. We see type 1 carcinoid type tumors associated with MEN1. We can see lesions in the parathyroid glands, in the pituitary gland. In von Hippel-Lindau, we see neuroendocrine tumors of the pancreas as a manifestation. SDHB, SDHD, we see neuroendocrine tumors form in the adrenal glands, and paragangliomas in sites outside of the adrenals. Tuberous sclerosis mutations, we see familial and can see neuroendocrine tumors associated with those lesions. So there's quite a few familial syndromes that neuroendocrine tumors are a manifestation. And that's allowed us to really better understand some of the mechanisms that lead to these tumors. And I think that has brought to the fore more targeted therapies for these lesions. When you look at treatments like everolimus, everolimus was developed directly as a result of a better understanding of the role of the mTOR pathway in these neuroendocrine tumors. And those insights came from studying the familial versions of these diseases. And fortunately, what we've learned from studying the familial syndromes are often directly applicable to sporadic cases. In pancreatic neuroendocrine tumors, about 30 or 40% of sporadic tumors have a mutation in the MEN1 gene. And so by understanding its role in the familial version, we can better understand mechanisms that may happen sporadically in patients without other family members presenting with the disease. So I think there have been tremendous insights from studying the familial cases.
It's amazing. It's amazing. So Rutgers University just opened up this beautiful cancer center. What was it, in August? Was it?
Yes.
So August of 25. We were lucky enough to get in September and give it a test spin. At that facility, we were talking about some new treatments and stuff like that. Are you guys at all involved with any clinical trials or anything new research wise that you're bringing to the table in the NET space?
Yeah, so great question. So first, with that great intro, I'll just spend a minute on the new facility. So the Jack and Cheryl Morris Cancer Center, which is the first freestanding cancer hospital in the state of New Jersey, and one of only 13 freestanding cancer hospitals in the country, is the result of a partnership and collaboration between RWJBarnabas Health, our health system, and the Rutgers Cancer Institute. The facility, as I mentioned, is a hospital, 96 inpatient beds, 9 operating rooms, imaging capabilities, PET scans, CT scans, MRI scans, all in one place, exam rooms, infusion chairs, radiation oncology suite with 4 state-of-the-art linear accelerators, including an MR linear accelerator, which is only one of a few in the country right now. And research facilities, so brand new research laboratories for us to be able to recruit new principal investigators to really focus on pushing the envelope with new therapies. And so we have a major research effort at the Rutgers Cancer Institute focused on neuroendocrine tumors. My own laboratory still continues to focus in that space. And the areas we're most interested in now really fall into three categories in terms of research that we're pursuing. One is we are still very focused on the mechanisms involved in neuroendocrine tumorigenesis in multiple endocrine neoplasia type 1. We've developed some of the mouse models that are used across the world, focused on tumors that occur in the setting of MEN1. And we're making tremendous progress in just understanding the basic biology of why the mutation in that gene leads to tumor formation in specific tissues and not in others. We know in MEN1 patients, they don't have a higher incidence of colon cancer, let's say, or prostate cancer, or lung cancer, some of the more common cancers, yet they have a much higher incidence of tumors in the pancreas or tumors in the pituitary gland or the parathyroid gland. And so understanding that tissue specificity is something my lab has been very focused on. The second major area we're interested in is in developing immunotherapies for neuroendocrine tumors. And we are working now in close collaboration with another Big Ten university, the University of Iowa. I've been working as a collaborator with Dawn Quell and Jim Howe and a number of other investigators at Iowa for many years, going on close to 12 years plus now since we first started doing collaborative work together. And I'm very excited to say that the University of Iowa and Rutgers University were successfully awarded a neuroendocrine tumor spore grant from the National Cancer Institute just last month. And we have three projects that are looking to translate findings from the lab directly into the clinic. And one of those projects focused on enhancing immune responses to neuroendocrine tumors is co-led by Dawn Quell and myself, a real partnership between the University of Iowa and Rutgers University. And then the third area we're very interested in is developing or assisting in the development of next generation targeted therapies, especially radionucleotide based targeted therapies. And we have some collaborations starting in that space. And I'm hoping some new clinical trials that will come online with sort of the next generation of therapies beyond the currently available PRRT type approaches. And so, yeah, we haven't stopped our momentum or lost our enthusiasm for research. And the research that we do is all geared towards translating to clinical trials and ultimately new therapies for patients with NETs.
It's amazing. It's really, really awesome. And yeah, University of Iowa, another another NCAN ally. We love those folks over there. That's very exciting. Very, very exciting. I'm excited to see the work that comes out of it and the studies that come out of it. Some of the papers that we're going to be in store for. When does this all officially start moving?
So we launched the new spore about 3 weeks ago with the receipt of our notice of award from the NCI, and that program will be in place for 5 years before we have to compete again to look for another award. I should mention that University of Iowa was the first neuroendocrine tumor spore and only neuroendocrine tumor spore funded by the National Cancer Institute, was originally awarded to the Otoricios back during that first award. They provided my lab with two pilot awards to assist us in our research around the immune responses to neuroendocrine tumors and leveraging the body's own immune system to fight those tumors. And those pilot awards led to new findings, discoveries, and publications that ultimately grew into a project within the new SPOR. And so I'm very proud and excited to work with that team and with Dawn specifically on our project within the SPOR. And so it officially launched in September, early September. We're excited. We've already held our first several meetings. The projects have all launched. And so we're looking forward to the positive output from that SPOR award that will lead to new treatments for NET patients.
That's awesome. That's more great information than I could have thought I was going to get this morning recording this with you. That's really, really great. So I do have some of these other questions. Sometimes they're in an emergency break class, but I do want to cover a couple of things. First, I do want to ask, what do you think is the most important thing a NET patient can do in regard to their care?
Be an advocate. It's very important with rare tumor types. We proudly wear the zebra pattern on the ribbons, et cetera, to acknowledge the fact that most physicians, when they're diagnosing a problem, think horses, not zebras. And that's important when you're in practice because you don't want to go down a rabbit hole or get distracted chasing something that may not be real. But for neuroendocrine tumor patients, it's real. It is a rare tumor type. And so advocating with their physicians, looking for centers of excellence that focus on neuroendocrine tumors. There are many across the United States. I mentioned my partners at Iowa, but there are many others all across the country now. I run the risk mentioning others, leaving others out, but there's no shortage now of major academic medical centers with a neuroendocrine tumor focus. There are designations now of neuroendocrine tumor centers of excellence that institutions have. And so advocating for yourself, if you're at a center that does not have a focus on neuroendocrine tumors, advocating with your providers to at least get the input of experts. As we talked about earlier, Mike, we have the luxury with these tumors of sometimes being a more of a sniper as opposed to a bombardier in taking care of these tumors. And we want to make sure we stage the therapies appropriately, always balancing efficacy against toxicity, since patients can live a very long and fulfilling life with the diagnosis. We don't want to treat them and have them be the victims of the treatment being worse than the disease.
Sure.
And so I think advocacy, if they're confused or don't know where to start, reaching out to groups like yours. Your mom and dad have been amazing leaders in this field in making information available to patients, having events like the one they just had at the Jack and Cheryl Morris Cancer Center focused on patients. I think they know, have more names in their Rolodex in terms of connecting patients to experts than I do. And so I think that's the most important thing. Be an advocate for yourself and find groups that will help advocate for you.
Absolutely. Absolutely. Something that I actually want, I've been trying to bring this into the show because I do feel like this is a little bit of this is something that's been kind of missing from being an audience member to any of these programs or the conferences or anything like that throughout the years. But what I wanted to see is, does Rutgers, does your particular facility, do you guys have any kind of resources that you provide to NET patients post-diagnosis? Because I know a lot of people, they get the diagnosis and then they go to Google or they'll go to Facebook and that tends to be a double-edged sword. But is there any kind of support, advice, support information, connections to social working or mental health experts guidance in palliative care, anything like that that the University of Rutgers will provide post-diagnosis?
So, specific to neuroendocrine tumors, we certainly help connect and guide patients to advocacy groups so they can, be able to benefit from discussions and interactions with other patients and really understand what the journey's like, and that there's tremendous hope, and that there's light at the end of the tunnel. But the other services you allude to, we have for all types of cancer patients at the Rutgers Cancer Institute and the Jack and Cheryl Morris Cancer Center. So we have nurse navigators that are engaged with the patient from the very beginning of their diagnosis, that help to navigate them literally through each step of their journey. We have social workers, we have psychosocial support services, we have overall support services, we have programs to assist with transportation, programs to assist with food access. We really see ourselves, RWJBarnabas Health, which is the largest provider of charity care in the state of New Jersey by a factor of 2. We see ourselves not just as a health delivery system, but truly a health system, improving the health of our communities. 9 million people in the state of New Jersey, and we care for more than half of that population. And so we really take our role and responsibility as improving health throughout our state and beyond very seriously. We're the only Rutgers Cancer Institute, the only NCI designated comprehensive cancer center in the state. And we take that role very seriously in providing education, screening, advocacy, very engaged with our communities to improve the outcome of all patients with cancer, and certainly NET patients fit into that.
That's great. I do find that, I've had quite a few of these conversations, and the post diagnosis mental health stuff, or again the palliative care things, I feel like a lot of the professionals that I speak to don't necessarily know the direct connection between that. I guess the nurse navigators are really the facilitators of all those things, but I kind of want to drive home that there are services, there are programs, there are different things within your local health system that can help you. Whether or not your immediate doctor knows that information right away, you don't know, but definitely talk to them. Definitely speak to the professionals that are caring for you, because they will help you with all that. They can help you guide you through these difficult situations. And I personally want to kind of shed a little bit more awareness on that as well. So this way people don't think that they're alone after their diagnosis.
Yeah, totally agree. And I could not agree more with your emphasis on those issues. I think that gets into advocacy, advocating for yourself and going to centers of excellence where those sort of support structures are in place.
Absolutely. So before we sign off here, do you have any kind of like a tip or trick for NET patients that may be something that seems very obscure, or maybe something very obvious that just needs to be just retold again? Because I feel like there's a lot of tips and tricks that are right in front of us, but we always look past it. Are there any of those that you have for NET patients?
I think my biggest one is, again, know that you're not alone, that while it's a rare tumor type, there are many patients who are going through the same journey as you, that there are support groups out there that can help answer questions. There's a lot of misinformation. Dr. Google can be great and it could be terrible in
Double-edged
terms
sword, yeah.
of misinterpretation of things. It could be very scary, and having someone help you navigate that journey is real important. And know that there are centers of excellence across the country focused on this disease that are there to help, there to apply the best available treatments and strategies now, but are also pushing the envelope for the next generation of treatments. And it's been an amazing journey so far. The last 30 years have seen us go from just one or two available therapies to dozens of logical approaches and combinatorial therapies and things that are very, very effective. And I can't wait to see what the next 10 years are going to bring in terms of progress in this area. And so never lose hope. Look to make sure you're seeking assistance and guidance. And most importantly, you're not alone.
That's great. And I you brought up Dr. Google. I do think that it's changed quite a bit over the past year or so with the AI function in Google. Please make sure if you do Google something, vet the information. Don't go by what just pops up on the AI answer for Google. It's pulling from Reddit. Reddit is it's the Wild West. There's a lot of misinformation out there. It pulls from Reddit. It'll pull from reputable sites. It'll pull from Facebook. It'll pull from a lot of things. So please make sure you're vetting the information that you get when you do look up from Google. But Dr. Libutti, thank you so much for spending time with us. I know you're a busy guy. I know it's the middle of the week, so you got a lot going on. So thank you once again, everybody. Thank you for joining us. Please sign up for the walk. We have the gala coming up, our 22nd gala coming up in November. You can get all that information at netcancerawareness.org, or you can follow us on social media at netcanceraware. And we will see you next time on Let's Get Real.
Thanks, Mike.